All right, let's go ahead, Hannah. Morning, everybody. Just getting the last few people from the waiting room, and then we'll get started. Okay, welcome everyone to today's session on achieving equity in vaccine rollout, integrating social support programs to build healthier communities. So today is our third vaccination webinar that we've offered as a U.S. Public Health Accompaniment Unit learning team. And we're really thrilled today to have an exciting group of case study presenters, as well as 2 keynote speakers to kick us off. Melissa, if you could go to the next slide. The run of show today will be a quick welcome and intro, followed by some opening remarks and an overview of resource provision in the context of vaccination, before we hear from 3 groups from around the country: Immokalee, Florida, the city of Montgomery, and North Carolina. We will close with a Q&A period with all of our presenters and speakers, and then we'll have a quick feedback poll at the end. So when we do get to that Q&A portion, we have a few questions prepared, but we would love to hear from all of you. So as we go through the presentation today, please ask your questions in the chat. If we don't get to them in the chat, we'll ask them in the Q&A portion. So please use that liberally. Next slide, please, Melissa. Okay. So we have many organizations in attendance today representing a large portion of the country. I won't read these off, but glance through. If you don't see yours here, or if you do, please introduce yourself in the chat. Tell us who you are and where you're joining from, what your role is in COVID response. We'd love this to be a platform that will continue to create connections across public health response in the US and beyond. Next slide, Melissa. Okay. So to start off our session today, I'd like to introduce our first keynote speaker, Dr. Joya Mukherjee. So Joya is the Chief Medical Officer of Partners in Health. She's also an Associate Professor of Medicine at the Brigham and Women's Hospital and an Associate Professor of Global Health and Social Medicine at Harvard Medical School. Really pleased to have Joya with us here today to open up with a brief explanation of Partners in Health and our work, global work in resource provision around the world, and how we're trying to bring that into the context of COVID response. Joy, I'll turn it over to you, and thank you for joining us today.
Great. Yeah, and we'll be welcoming Shada Rouhani afterwards, who has been our technical advisor on resource coordination and is the director of emergency care at Partners in Health. So it would be great to have Shada as well. Next slide, please. So, one of the things, and, you can see my hair has grown quite long in quarantine. I now have a ponytail. I haven't gotten a haircut, and I can't deal with contacts sometimes with all the Zoom. So I look a little different than my picture, which is from last year. So, Partners in Health is a more than 30-year-old organization now. We are started in Haiti and really worked together with very poor people to look at what needs they had. So people talked about health, they talked about education, but they also talked about job security, food security. And we recognize that health is deeply connected to what are sometimes called the social determinants of health. And I and many of my colleagues, across the world, as well as on this call, we consider ourselves practitioners of social medicine. And so what that means to us is that we only can effectively deliver healthcare and achieve equity if we address the social determinants of health, which are really the social forces. They're forces, they're active, they have a direction, they have a magnitude. There are things like racism, redlining that results in overcrowding, who is considered an essential worker or not, who has health insurance. These are really these social forces, and equity, health equity demands addressing them. And so when, some of you may know the term targeted universalism. We say preferential option for the poor. They both mean similar things, which is that if you give everyone the same thing, you will continue inequality, because people who are poorest, most marginalized, historically and in present day, need additional resources. So that to us is captured in the notion of accompaniment, which is really walking with people to where they are, to giving them what they need to be healthy. And this is on the right is a picture of a couple of our community health workers in the very beginning of the COVID-19 pandemic in Peru. And these are people who live in the community. They know the community of Caraballo, which, as you can see, is a poor community. It's a slum community in northern Lima. We didn't know how infectious it would be for people to do household visits, but they really were committed to visiting the very people in Caraballo who were most at risk. And they did both COVID testing, continued work to test and treat TB, and even things like food delivery. So this is really the idea of targeted universalism, making a preferential option for the poor, or this idea of accompaniment. So when we talk about the human rights approach at Partners in Health and what it takes to deliver healthcare as a human right, we look at that as a dialectic, two things that work together but are sometimes in opposition. One is the civil society, the engagement of the community, targeting and working with people who are most left out and advocating on their behalf. And the other is to support the public sector, the departments of public health, public facilities, which have often been underfunded, to do what their mandate is. And often these things can work together. Sometimes they work in opposition. And how do we do that? Well, social support is the patient side, community organizing is the patient side, knowing the community, hiring people from the community. And then on the facility side and the community side, it's about increasing staffing, about making sure people have the supplies they need, like PPE, like test kits, making sure there's adequate space in facilities to do proper triage, to have electricity, running water, and then the systems of communication between these two sides, community and the public sector, but also within the health system. So we consider those the 5 S's: staff, stuff, space, support, staff, stuff, space, systems, and social support. Next slide. So I have an engineering background, and I often think of the way we tackle health problems as this engineering diagram. And the reason I like that is, I was taught about the social determinants of health, and it sounds like they're actually determined. It sounds like they're fixed, but we understand them as a force that has a magnitude and a direction. And so every time we're dealing with a health problem like COVID, you have things like the biology, the variants, etc., the social forces, the political, that can tip the pandemic into chaos. And so our job is to push back, go back one click, please. Push back on those social, biologic, political forces with care, with programs to fund equity, develop trust, and have good leadership. So this is, COVID is a neutral thing. But why is it impacting communities of color so much more severely? Why is it become this red state, blue state divide? Because of these social forces. So a lot of our work in COVID around the world, but particularly in the United States that we're going to be talking about today, is to use these social forces that we can control, care, resourcing equity, establishing trust, working with leaders who care about it to combat these other social forces. Next click. And that is what we call accompaniment. So really wrapping our arms around what are the interventions that can really defray these negative forces and help us to get control of the virus. Next slide. Next slide. So we will not be talking a lot about the Massachusetts work, which is under kind of a separate envelope, but just to say, due to our global work in Peru, in places in Africa, in Haiti, Mexico, etc., we were asked by the governor to help stand up a contact tracing program. And again, we saw this as this two-pronged approach. We're going to help the Department of Public Health to meet their mandate because that's what they want to do, that's what they should do. But of course, we know that this terrible tsunami of the virus outmatched any chance that really under-resourced public health departments had to do this. But then secondly, try to figure out what the community needs and what's the equity agenda for that. So we put in place a mechanism by which we would do case investigation, contact tracing, many of you familiar with those two things, but then add a component that was really geared toward equity, which is what we call the resource care coordination. So asking people, telling people these are the things you need to quarantine, isolate, can you do that? And if the answer is no, because it's overcrowded, people, have to go to work, they don't have childcare, then that third cadre really is the equity focused cadre. Next slide. So that is what we're going to be talking about today, is how, again, what we see as we universalize vaccine, we're all excited about how ramped up the vaccines programs have become, since the President Biden took office, and really the access that people will have. But again, if you make universal a service, you're not going to improve equity. Specific targeted programs are needed to develop equity. We need to make a preferential option for the poor. And we know already with vaccination that there are huge discrepancies in who's getting the vaccination. So with that kind of history, I will turn it over to my colleagues who are going to tell you a bit more about how we're thinking of doing this, how we are doing this in some of the places that we're working. Thanks very much.
Thanks, Joya, for that great introduction. It's my pleasure to talk with you guys for a few minutes today about how we're thinking about resource coordination and this way that we can make this preferential option to really use vaccination as a way to improve equity. Next slide. Many of the challenges that people have accessing social supports to really address these social determinants of health that Joya alluded to are unfortunately mirrored in what we see today with people having challenges accessing the vaccine. The reality is that there are multiple barriers for patients who need to access the COVID vaccine, and those barriers are greatest for populations that are often marginalized, including those who are low income, non-English speaking, or who are historically marginalized or have other barriers that make it difficult for them to navigate the current systems. And these barriers range from things that are structural, such as limited access to a healthcare provider, or limited social support and limited information systems that make it difficult for people to navigate a complex healthcare system to sign up for vaccination or to make it to a vaccination site. There's also information barriers. Information about vaccines right now is being inequitably distributed and not adequately reaching all segments of our population. And then there are logistical barriers. Vaccination currently is offered at, unfortunately, a small number of sites that often have barriers to getting to them, be it that they're not at a convenient location for populations, or that the hours that they're open are not conducive to work schedules, or that there's simply an inability to schedule an appointment because vaccination appointments may only be available to be scheduled online, which we know internet access is not always equitable amongst groups. Next slide. As Joya alluded to, resource coordination, or this idea of helping identify what support someone needs and then providing those supports to help someone achieve better health. And in the context of COVID, traditionally talking about being able to safely isolate and quarantine through these supports. We know that this has improved outcomes for, or we know that this has improved ability to isolate and quarantine in the setting of COVID. And that's often been done through the use of resource coordinators, sometimes called care resource coordinators. CRCs, or care resource coordinators, have a unique role where they can build trust with the individuals that they work with, help individuals navigate very complex and difficult social service systems, and then act as their advocates, really accompanying them and bringing them forward on their journey and tipping the scale that Joya alluded to have better health and better outcomes. We've seen around the country that CRC type roles can be fulfilled by a number of individuals, including community health workers, social workers, trained, dedicated workforces, community nurses, and others who are really trained in needs assessments as well as resource provision. And what we're now seeing is an opportunity to use those same workforces and the same lessons learned, the principles that we've seen so successfully applied over the last year to really improve the vaccine rollout. Next slide. So when we talk about the resource coordination and vaccination, we're talking about two different opportunities here. First is to improve equitable access to vaccination. And this is breaking down those barriers that we were talking about earlier and that Joya alluded to. And we know that so far the vaccine rollout has been very inequitable. And we know that these structural barriers exist and need to be addressed if we're going to achieve equity in vaccination rates amongst the population. And so CRC programs or similar programs can really work to proactively reach out to the most vulnerable, break down those barriers to access, and overcome those structural, informational, and logistical barriers that are currently keeping populations from reaching the vaccine. And then second, we have an opportunity to use vaccination as a moment to actually improve long-term equity. We know that the heaviest risk of infection from this pandemic has come from those who are the most marginalized. And we know that those same populations have also borne the heaviest brunt of the economic crisis that we've seen over the last year, with highest rates of unemployment, high rates of rental insecurity and food insecurity. And as Joya was mentioning to us, those things all affect your health, but they are all addressable. And so we have a moment here where we're going to have people interacting with the public health system where we can actually take that moment and use vaccination as an opportunity to connect vulnerable individuals to the healthcare system and to social services to meet long-term needs. Next slide. And so there are three major components that we're thinking through here. First, outreach, and we're going to hear about this from several of our speakers today, talking about efforts to use CRC programs or CRC-like programs to proactively reach out to the most vulnerable individuals, answer questions about vaccination, and help walk them through the sign-up systems to get appointments for vaccination so that they can have access to these services. And then in addition, we're going to hear about efforts to improve scheduling systems, including staffing incoming call lines in addition to online vaccination systems, and actually allowing and working with outreach workers to directly schedule appointments and help people navigate those complex sign-up systems. And finally, we're going to hear about from some of our speakers about efforts to improve actual physical access through transportation options to vaccination sites, to help people reach places that may not be accessible to them otherwise, as well as thinking about where vaccination sites are physically located and using pop-up vaccination sites and or home vaccination programs to reach homebound individuals. Next slide. When we think about leveraging the vaccine rollout to address social support needs, again, as I mentioned, this is going to be a moment where hopefully a huge proportion of the population is going to interact with the health system. And for many people, this is going to be a rare touch point. And so this is our opportunity to really coordinate access both to social supports and to healthcare. Next slide. So as we think about how this can be done, we're going to hear from some of these options from our speakers today and others that I know are being discussed by teams around the country. But one is thinking about how can you screen for social needs at the point of vaccination, either at the time of registration for an appointment, while you're waiting for vaccination, or even during the observation period after a vaccine dose administration. And then once that screening is done, taking it the next step and linking individuals to resource coordinators or to others who can help connect people directly to resources in the community, both short-term and long-term, to help them address the social determinants of health that are currently affecting them. And we know that many of the public assistance programs right now are actually under enrolled. And so this is an opportunity for us to identify people who really need that support and help them navigate the systems to be able to get that support. In addition, vaccination offers an opportunity to distribute information broadly about locally available resources, and importantly, an opportunity for us to help reach some of our non-English speaking patients by having availability of information as well as resource coordinators in multiple languages to help speak to people in the language that they need, so that they can have the information that can be most helpful to them. And finally, we're seeing around the country that some people are using the vaccination sites as an opportunity to actually directly deliver services through partnership with food pantries and local organizations to make services available directly at the site of vaccination. I do want to take a moment just to mention that if these options are pursued, or as these options are pursued, it is really important that all of these resources are clearly available to all, independent of the decision to be vaccinated. We certainly don't want to create a situation where there's either a perception of coercion or actual coercion into getting the vaccine. And we want these services to be available to everybody, regardless of if they've already had their vaccine, but have a new need that's emerged. So the vaccination sites are really an opportunity for us to connect both with the people being vaccinated that day, as well as the communities around them. Next slide. And finally, similar to screening for social determinants of health, the vaccination encounters an opportunity for us to screen for access to healthcare. We know that health insurance coverage remains inequitable within the country, and we also know that access to primary care, which is so important to long-term disease outcomes, is also inequitable. The vaccination encounters a moment for us to screen for whether somebody currently has insurance and or primary care, and then take that time to connect them to programs that can support those things, including federally qualified health centers that are often skilled at navigating services and healthcare for individuals who have barriers to traditionally accessing those services, and as well as clinics that can provide sliding scale payment options, so that even if somebody is unable to qualify for public insurance, they may still be able to access ongoing preventative care through sliding scale payments that can often slide down to zero depending on patients' incomes. And it's worth mentioning that right now, many of the state marketplaces, as well as healthcare.gov, the federal insurance marketplace, they're actually reopened for enrollment. And so there is a very active opportunity at the moment to reach individuals without insurance and help connect them to options that can meet their own situation. Next slide. All right, and with that, I'll turn it back over to Janae to introduce our panelists, who are going to give us a little bit more detail about some of these options that we've heard today, and give a little bit more context about how these opportunities can be implemented around the country.
Thank you so much, Shada. And as I introduce our panelists, I'm going to ask Melissa to advance actually to slide 24. We're going to change up our order a little bit. And we're going to start off with Philip Ensler, who is Senior Advisor in the Mayor's Office in the City of Montgomery. And he will be speaking to Montgomery's work in really providing a robust vaccination response in the city. He has to jump off for an urgent meeting with the mayor. So we're going to, I'll save the other introductions for after this piece of the presentation, but want to welcome you and thank you so much for your time, Phil.
Sure, no, and thank you for being flexible. You know, it always seems to work out that way, that when my schedule's wide open, you know, I have nothing, and then when it's packed, that's when he wants to meet. So I appreciate, you know, being flexible, but it's great to be here. You know, Partners in Health has been a tremendous help in our COVID and vaccine response so far, and really helping us think through. If you can go to the next slide, please. Yeah, and just to give a little bit more on the health side of our landscape here. We have a state health department that's very centralized, and then we don't even have county health departments. We have regional administrators, and then we have emergency management offices. None of those are within the sole or direct purview of the mayor. So we find ourselves with our hands pretty tied as far as deciding, vaccine allocation and sites. But what we're trying to do is influence as much as we can those stakeholders, and trying to encourage them to think about things in a more equitable lens. That is a term that our office uses frequently, but it's not always in the day-to-day conversation or even perspective, of some of our other partners. So we find ourselves, having to really explain why, reaching people where they are, why having, rides and more wraparound services are things that will really make this a more fair and equitable process. But we are encouraged by the direction that we are moving in. We have been able to do a few things, starting with making sure primarily that we get the word out. And I think if you can jump to the next slide, that'll have, yeah. So, one of the biggest parts we've started with is just the education piece. We find that as much as the local news, may cover where the vaccine sites are and the times, that, the people who want to go, to those are going to go, but doing that education on the front end for people who are hesitant. So we've done a series of virtual town halls that have been targeted, at certain groups. We even did one of the best ones was for public school teachers here, a lot of whom are hesitant or have concerns, and even stuff as simple as, can you take Tylenol before you get your shot? Can you take it when you get it after? Those are questions that people have. And we found doing these virtual sessions where the mayor will kick them off, and then we have a local doctor, went to some of the public schools here, who is in the same fraternity as some of the teachers, goes to one of the churches here, that many of them go to, and just having him share and answer those questions and give people a space to really find out, and ask what's on their mind, has been really helpful. And we haven't gotten hard data on it, but just even anecdotally, people who were on the fence who then went to those sessions, and then have told us after, hey, that's what put me over into the category of going. So I can't emphasize that enough of that really targeted education is really important, and then engaging clergy, community leaders, with fact sheets, with information that they can give out, whether it's virtually through their services or email out, to their congregations. That has made a tremendous difference in getting, the right information in the hands of people, who then feel more confident going to our clinics. With that said, that so far we've had a few mass drive-through clinics, and the headlines are great. Thousands of people have gone. They've run very efficiently, and that's been huge for us. But from our office, we recognize that those aren't always accessible from a transportation standpoint, for everybody in town. And as much as Montgomery is known for its history, of Rosa Parks, and seeking a equal and fair public transportation system, public transportation here still is very inequitable as far as access. So we launched a program where we started by contracting with a female Black-owned transportation company. And what we did was just put out the number for her operator, and we had people from homeless shelters who were able to get rides through that service, and other individuals who either, don't have a car or, the bus route doesn't go near them. And we're going to continue that. And that now will allow to bring people to appointments that they may make, at different providers, as well as the mass clinics. In addition to that, though, we are going to partner with Uber, and they've been great in working to provide, free round trip rides. But even on that front, we will have vouchers or codes that people can use if they have the Uber app. But knowing that a lot of people may not have that, we'll use our local 211 number where people can call that up. And 211 will use the Uber Health platform to schedule rides for people that way. So that's been huge. The other part is also where the vaccine clinics are. The mass one we've done was in the heart of the city. And, we are a small city, so it's mileage wise, not too hard to get there. But we recognize that, going and meeting people where they are, just makes things that much easier. So one thing that we've done and I'm excited about is not next week, but the week after, we'll have one of the mass vaccine sites on the west side of Montgomery, which is one of the most underserved parts of town. And even though we know and anticipate people from all over, the city will drive there, just sending that message of, hey, we are going and bringing this into a certain part of town, into a certain neighborhood, will speak volumes. And the last part, just at those vaccine sites, while we have so many people showing up, we recognize that there are people who may have multiple needs. And so if they're there, whether it's access to a food pantry, whether it's an access to other, health services or resources, we've started to bring more of that on site. We did that at one of the mass vaccine clinics where there was a food pantry, and we look to do those in future ones. The biggest challenge with that, though, is buy-in. And, again, we have stakeholders who, view it as, hey, this is just for vaccines, that's kind of the sole purpose. So getting, people to think differently and say, hey, yes, having multiple services available is needed and makes sense. So I have one last slide there. And yeah, and this just shows, and Partners in Health helped with this, of just, looking at what areas are the most high risk. And the west part of town there in that dark red or burgundy, right in the heart of that is where we'll have, this clinic in a couple of weeks. So I hope that we can continue to use this type of data, to influence the conversations and think about how we make it equitable. But that's everything I have for now. And I'm happy, I'll drop it in the chat, my email address. If there are any questions about any of the things we're doing or any follow-ups, happy to answer those as well.
Thank you so much, Phil. And we really appreciate your time today. Feel free to jump off to your meeting, and we'll circulate any questions that come up specifically for you. Melissa, could you go back to slide 18? I'll also say now that we have one of our Partners in Health technical advisors on the line who's working with Phil in Montgomery. And so if you do have questions specific to Montgomery, please still feel free to put them in the chat now or later. And Grace, our colleague, will step in to answer some of those. We will now transition to a presentation from our colleagues in Immokalee, Florida. So we have with us today Julie Pedretti, who's COVID-19 Community Relations Director with Healthcare Network in Florida. Joining her is Madania Hinojosa, who is a community health worker promotora with the Healthcare Network COVID-19 response team. So really, really excited to have such a frontline worker on the call with us today. Joining them is Caroline Murtaugh, who is a project manager from Partners in Health working with Immokalee. And I think that Julie will be kicking off the presentation, so I'll pass it to Julie.
Good morning, Julie Pedretti, and I'd like to provide just a short introduction to Immokalee, Florida, to Healthcare Network, and to the Healthcare Network COVID response team. First of all, Immokalee is located in Southwest Florida. We're in Collier County. Population of about 29,000 people, 45% poverty level. It is a migrant farm worker community. Farming is the basis of the economy here. And Healthcare Network, which is a primary care provider, a federally qualified healthcare center, a community health center, was created in 1977 to address the medical needs of that farm worker community. So we've been around a long time. We have multiple centers throughout Collier County, but we're going to focus today just on the Immokalee area. Our growing season is from October until May. I'll talk a little bit about our COVID work, but we're a little bit anxious around vaccines right now because we have the farm workers with us for just another couple of weeks before they typically head north into the Carolinas and beyond. So we are a primary care organization, and what's so spectacular about the way we do our work is that we provide not only medical care, but also behavioral health and dental care in our facilities. So people can get all of the care in one place. Our population is Spanish speaking and Haitian Creole. And the Haitian Creole population has been growing dramatically in the last couple of years. Many of the people who come in are bringing other people in to work in the packing houses. So we have mostly Spanish speaking in the farm fields and mostly Haitian Creole in the packing houses. Of course, there's some variation, but that's kind of how things have worked out. So it's important for us in our staff at Healthcare Network and also on our COVID team to have the language, the Spanish and the Creole speaking participants. Next slide, please. So I'm going to talk just a little bit about the formation of our COVID response team. We received a large grant from HRSA in May, June timeframe, and the decision was made to form a team of people who could be out in the community, building trust, educating. The whole idea was education and testing at the start. And of course, now we're moving into vaccinations. So the team was recruited during the summer. We worked alongside the Department of Health, and we do have a very strong Collier County Department of Health. They had promotoras on staff. They were being trained by Partners in Health. So we decided, well, maybe we could just tie in with the training that they're doing for their team and learn from them as they had already gotten started. And we were just ramping up in late August and September. Well, the Department of Health promotoras were college students and they were moving on to other jobs. So the Department of Health asked us to really take on the community health worker promotora role, which we did. And Partners in Health has been an incredible partner with us, not only training, doing the promotora training, but also helping us connect in the community. We have so many wonderful partnerships with the Coalition of Immokalee Workers, with a group called Mission Peniel that's providing social support. So we started last fall doing a lot of canvassing in the neighborhoods, going actually door to door, educating, providing as much community testing as we could, doing pop-up testing events. But I think our testing really had its greatest impact in January when our team was expanded and we were able to set up our mobile unit to provide rapid testing about 3 times a week in specific neighborhoods throughout Immokalee. At that same time, providing rapid testing, we were able to find people who tested positive and provide the social support immediately to those individuals. And Caroline and Madania will talk more about that in just a moment. So I also want to just talk briefly about some of our early vaccination efforts in Immokalee. Next slide, please. And then turn it over to Madania and Caroline. So in Florida, everything here around vaccines is managed by governor's executive orders. And until just this week, only people 65 and over could be vaccinated. We are not able to vaccinate migrant farm workers unless they are 65 and over. On Monday, that age changed to 60. At the same time, our system in Collier County was, for signing up for vaccines, was from a website, English only. It required that you have a computer. It required that you be able to access these links quickly and get signed up. And the first vaccination events were in Naples, and then there was one in Immokalee. On the day of the Immokalee vaccination efforts, what we learned is that out of all of the appointments that were made, all of the vaccines that were given, only one was provided to an Immokalee resident. Well, that wasn't going to work. So working again with the Department of Health, Partners in Health, all of our other partners, we started to reach out to the populations that we wanted to serve. So it was our patients 65 and over. We asked community groups to identify people 65 and over, and then we were able to set up the next vaccination event, 100% people from Immokalee, Wisconsin. And I'm going to turn it over now to Mandanya and Caroline to talk about some of the efforts that are taking place in Immokalee to serve the community.
Next slide, please. Great. So our goal with our health promoters who are from Immokalee, so our health promoters understand sort of the social structural context where we're working and really understand how to make some of these solutions feasible in the Immokalee community, is to overcome some of these structural barriers that we were witnessing to vaccination that were barring a lot of people from Immokalee from receiving these services. So Madania is one of our awesome health promoters and is going to talk a little bit about the work that we've done with this team to support more people to access vaccinations.
Yes, the way what we're doing is we go canvassing, and from there we start collecting information for everybody who interested to have the vaccine, and provide also the transportation for those persons that they don't have a transportation for the day of the vaccine. We just let them know the time and the day that we have the event, and we go pick it up and drop off at the location, and we there onto the vaccine completely and drop off back to the house. That's the way that we do it in here.
Yeah, exactly. So with our team of health promoters, so we go door to door and we ask people if they're interested in getting vaccinated. If they're not, then we also try to understand the reasons why people may face challenges to getting vaccinated and support them through those challenges. We also go to churches, we're on the radio. And so we're really just working at the community level to support people that get registered to get vaccinated. Once we have this list of people in the community who are interested in one vaccination, we actually help overcome that difficult registration process by making appointments for people. And in fact, when we can't reach people on the phone to make them an appointment, we'll visit their households and sign them up on the spot. And then as Madania said, up until the point of the appointment, we'll transport patients to the vaccination sites. There we'll greet people in their preferred language, using socially and culturally accessible information to support people through the process of getting vaccinated.
Yes, and as Miss Julie say, we have a three population in Immokalee: Spanish, Creole, and English. And at the time that we do the canvassing, we divide it by the group. We have one Haitian, we got one Spanish, we got one English. And when we knock in the door and we see if the Haitian, for the Haitian speaking, they start introducing our group, let them know what we are, what we doing, and if they're really happy, it's a really happy what we doing, and I think so it's great.
Definitely. All right, we can go to the next slide, please. Thank you.
Oh, that's me. Okay, and here is like you see, that's the transportation that we use it. For the people they don't have a transportation for the day of the vaccine, we let them know at the day that we called to let them know the day and the time. They will be providing transportation. Both we send the transportation to their houses. They waiting. If they need a special need, I'm really sorry, because a couple of days ago we have an event and we have a few patients. They needed a non-emergency transportation. Was really sorry for them, but we doing good. It was a really good idea, and they were happy because they don't have nobody they can take it. They don't have no transportation to do it. Yes.
Definitely. And just to lift up some of what Madania said. So a great, thing that we've had with working with our health promoters is, again, working with people from Immokalee who understand this context and understand what resources are available. A good example is this transportation system. So Madania is being very humble, but she actually owns a taxi company in Immokalee as well. And so we were able to work with her to understand, where to go and how to logistically arrange transportation for patients. And then I think, sort of just to close the loop, one other thing that we try to do while providing the social support during vaccination is to link to longer term versions of social support. So for example, when we're out in the community canvassing, going door to door to sign people up for vaccination, we also ask people overall, how are you doing? How are you handling COVID? And what other needs do you have? And that's a way for us to understand what needs exist in the community and how we can be better resource navigators to link people to resources to address those needs. So for example, I remember we were out, our team was canvassing at an elderly living facility, and we came across a woman who not only needed to be registered for vaccination, but also really needed clinical attention. And so we were able to refer her to the healthcare network, where she's now registered as a patient to get care for some of her other conditions. So our goal with vaccination is not only to stop the spread of COVID and not only to protect this vulnerable community from this pandemic, but also to link people to some of these longer term supports to continue advancing health equity and increase access to care. So I think that finishes off our presentation, unless Julie has anything to add.
No.
But thank you so much, everyone, for having us today. And
Thank
we're
you so
excited.
much for the invitation.
Yes, we're excited to answer questions as well.
Thank you so much, Caroline, Madania, and Julie, for that really empowering conversation. Incredible the work that y'all have been able to do in Immokalee, and I know that the chat's kind of blowing up right now with other people who I think want to do similar work. So thank you so much, and I'm sure we'll get some questions after the next presentation as well. So we'll transition now to our final case study presentation, which will be coming from North Carolina. So we have representatives of the Department of Health and Human Services, as well as Cure Americas with us today. And so we're going to start off with a presentation from John Resendez, who is with the DHHS. He's joined by colleague Andrew Herrera, who's Executive Director of Cure Americas within North Carolina. And I will pass it over to you, John, for the first part of your case study.
Thank you. Can you all hear me?
Yes, we can.
Thank you. So just to provide a little context, I'm the program manager for a community health worker initiative through the Department of Health and Human Services. And Andrew was one of the vendors we selected last year when we put out for proposal this bid for these services to help sustain this workforce. And so the 2020 vision for our department was to support people to stay at home through quarantine and isolation. And so what we thought was an innovative strategy would be to marry the workforce, the community health workers, to a support services program, which was a program stood up solely based on resources for social determinants of health and to help folks quarantine and isolate. So it provided individuals with financial relief, food, transportation, things of that nature, because that's all we heard in the spring was, I can't stay at home and quarantine and isolate because I have to go to work, to put food on the table, I have utilities and bills to pay, I have a life to lead. And so we try to put our money where our mouth was. And we made the community health workers the key holders for this resource, so they could be the key identifiers of these historically marginalized populations to get them these resources directly. And so with quarantine and isolation, we obviously wanted folks to stay at home so that we could minimize the spread. We have a digital healthcare platform called NC Care 360, which marries these referrals and resources together on one platform. So you could conceptually enter a client into NC Care 360, find and identify their resource needs, and make a direct referral to an entity or community-based organization in the community for that need to help that individual with that. Looking to 2021, we have fast-tracked into the vaccine space. And with that support service plan and scope of work in their back pocket, the CHWs have shifted towards vaccine education. We have a digital platform called CVMS, which is our master vaccine management system. So they can help folks register in that system. They can help schedule individuals, appointment reminders, help with transportation needs. Remember from 2020, they were already helping folks with transportation to coordinate those resources. So now shifting that model with resource coordination towards the vaccine has been the flavor of 2021. And Andrew's team is actually helping support a FEMA vaccine event in Greensboro, a town of ours in North Carolina. They're administering 3,000 vaccinations per day. And our Secretary of Health actually visited the site this week and gave a huge shout out to the community health worker team, saying that these HMP appointment markers yielded incredible results. I think it was 3 times our average HMP representation at these events. And it's all thanks to the community health workers. So I wanted to turn it over to Andrew to talk a little bit more about the details of their work and some of the topics to come.
Thank you, John. Buenas tardes a todos. Good afternoon. Thanks to Partners in Health for the invitation. Our partnership with the North Carolina Department of Health and Human Services has been really incredible due to the kind of forward thinking innovation of connecting the social support to help people stay home, isolated and quarantined, with the CHWs, community health workers, to help people have access to the health system. Our model has been to really bring health to folks, and the way we do that is through trusted individuals, but not to create the trust, but to really bring the resources to the existing trusted areas. And so at Cure Americas Global, we work with 19 partners, subcontractors who are already part of the community. Instead of competing, we decided to collaborate with the food bank, who already had trust, who was in the community before us and will be there after COVID. And really what they're looking for is the resources and the expertise to do it better. And so that's what we've been able to do, is to stand up over 200 community health workers across 26 counties. And we know that based on all that we've heard before, that access requires this trust. There's so many barriers to access, but the biggest one for us is making sure that people feel comfortable and confident. And the way we can do that with the populations that we're part of, our neighbors, is to answer the phone in their language, to proactively reach out. And at the vaccine sites that John's mentioned, we've done quite a few vaccine events. There's all these different pieces. You have the logistics, where to park, where to stand in line. You have the sign up. There's so much work to just get people signed up. You have the providers giving the shots, and everybody's really laser focused on their piece of this puzzle. The place that community health workers fill is the customer service aspect for the people who are often left behind or forgotten or not part of the traditional healthcare system. The community health workers are trained. They have both, information on general health and the vaccine in the vaccine event, but they're also aware of their community and how their community needs to be interacted with. And so what I mean by that is just saying good afternoon, making eye contact with people who look like you to make them feel welcomed, rather than just expecting people to get in line and pull out their phone and know what to do. It's really, opening that door and being the trusted person at the site at the beginning when they show up, all the way through the process as an ally, including at in the waiting period, to give information what's next, and to say, is it okay if I call you as a reminder and check up on you? All of this is so important at the vaccine event to ensure that folks have a good experience and can come back, and to include the social determinants of health screening as well. The key, to me, innovation of the Office of Rural Health and NCDHHS was linking these two programs, community health workers and the social support to help people isolate and quarantine. Because community health workers had access to this social support program to be able to actually register people for relief payments, for medication delivery, for utility support, for food, because they were able to connect clients, and they connected, tens of thousands. I was almost going to say over 100,000. I mean, it's a lot of folks at scale. Because they were able to do that last year, they had this list of community members who they had already been in touch with. That was easy. When they were looking at 65 and up, they knew exactly who they could call, who they already had a relationship with, to say, hey, are you interested? Do you have any questions? And not just that, but to call again and say, how are you doing? Do you need anything else? Are there, to go through that whole social drivers of health screening tool that's part of their toolkit. And so I think that those connections are really important. I would also say by bringing this healthcare to frontline organizations, it doesn't live in a hospital or a clinic or a health department. It lives in the local food pantry or in the local church or in the local existing organization that's been there for many years. That has really allowed this program to scale quickly. We're also building the workforce, the long-term workforce for our health system. One of the challenge of this is that we've trained so many people, but the funding, is really hard. CARES Act money or wherever the money might be coming from, if it starts and stops, the people who are affected the most are the frontline workers who need that check. And so that's been a challenge. But what I would say is that there have been lots of challenges, but it's not just possible, it's necessary. On a call this morning, one of our partners said, this is an opportunity with the pandemic to not do public health business as usual, but to update how we include from the beginning communities who have expertise. They don't just have connections. Communities have expertise, and everybody wants to be healthy. And so I just want to end with this reminder for all of us that all of us want to be healthy. We want our parents. How many on this call helped our parents get vaccinated? How many people on this call are, live and dream and sleep and work and eat health for our community? We all want to be healthy. And I witnessed a community health worker fight so hard to get a 65 plus migrant farm worker an appointment, a ride, and met that person at the vaccine event to walk them through the event. And I saw that man who works every day cry because he said, I cannot believe that you cared enough to help me get vaccinated. I surely didn't think I would ever get vaccinated. That's why we do it. And it can be done. It must be done. Thank you very much.
Wow, what a story to end on, and move into some questions where I think we can all start to understand more about why and how this can be done. And Shada's gracious enough to moderate today's question and answer portion. For all of you in the audience, please put additional questions in the chat, and we'll look through those as we start off with a couple of prepared questions. Thank you all for your presentations and for your incredible work.
Thanks, Janae, and thanks to all of our speakers today. We've heard some amazing work going on around the country. And I hope that all our panelists are able to join us here for a moment, answering some questions that have come both from the audience as well as that were sent in ahead of time. And as we mentioned, I know that Phil had to drop off from Montgomery, but we are fortunate to have one of our PIH team members here who is able to answer questions from Montgomery. So please feel free to drop questions for them as well. Starting off for all of our panelists, one of the questions that always comes up is thinking about how to start programs like this. And it often seems daunting at the beginning when you're looking at a problem such as access to vaccination and thinking about how to build systems to solve it. Can you think back to when you first started some of these programs? What were some of the key steps that you took to understand how to make these programs feasible? And what stakeholders did you engage with early on when thinking about these combination of resource coordination and vaccination efforts?
Yeah, I'm happy to start us off with the work in Immokalee, and Vidania and Julie, please feel free to jump in. I think something that worked well for us to start was to spend intentional time canvassing in the community. So when we first started our community health program, that's pretty much all we did for a few weeks, was go door to door and talk to community members and ask them, how are you doing, and really mean it, and try to understand what challenges people were facing in Immokalee specifically, And by, spending this intentional time with the community first, we learned two major challenges were, one, just lack of opportunities for testing, and two, lack of social support for people to overcome structural barriers to services like testing and vaccination. And so by listening to the community first, we were then able to build this very robust testing system where we actually do rapid tests. So as Julie said, 3 times a week in the Immokalee community. And so people receive the results right on the spot and are linked directly to social support through our partners at Mission Peniel, where they actually receive cash transfers to be able to stay home and miss work and isolate and stop the spread. And so I think, again, by listening first, we understood some of the challenges that people were facing to testing, such as with PCR tests, difficult to navigate portals for accessing results, times that testing was being offered that weren't accessible to people working in the fields. And then we're able to sort of overcome some of these challenges with these systems that we built together. And then I think would say the other thing that we did was really lean on local partners. So the Healthcare Network is a federally qualified health center that's been here for a long time and already has a lot of clinical connections in the community. But we also partnered with the Coalition of Immokalee Workers, which is a human rights organization that has been a very powerful community voice. And then Mission Peniel, which is a social support provider that already had this trust and could easily fill in as sort of the COVID social support provider.
Andrew, over to you.
Yeah, thank you so much. That's a good question. How do you start this? I think that one of the things that's really important is to listen and include from the beginning, but not just listen. I don't think, for us at least, like it's we can ask lots of questions and we have this checklist as, in terms of like community engaged research or how to do these things. I would also say though, listening means changing our plans based on what we hear. That's really hard to do because funding sometimes is really restricted or there's other guidelines, and that's really hard. The other thing that I've heard from our local partners is making sure they're at the table, not just at the table, that they have a spot on the agenda, not just a spot on the agenda, the first spot of the agenda, and not just to listen, but to actually often say, we're done listening, get out of the way so that we can do our work. That's what our partners keep saying. Get out of the way so we can do our work. We don't want to give you any more information that you can use in your report. We want to do the work. And that's where the state has really done. North Carolina has said, how do we get you to do your work? What can we do to get you to do that work? And that's what I really love about this model. I think that also being able to iterate very quickly, because June and July, when we wrote our proposal, looks very different from August 7th, looks very different from October. And what the state has done that I really like is this type of like relay team approach, where it's looking at what's next rather than just reacting to what's now. And so including the partners in that from the beginning on what's coming down the pipe. We know vaccines are coming. We knew that in November. How are we planning for that in November rather than reacting to it in March? And so I think those are two things that I think the state has done well and that I've heard from our partners.
Thanks so much, Andrew. Building on something that you alluded to during your presentation, Andrew, you mentioned trust. And I think this came up actually across all 3 presentations. Trust is obviously incredibly important for all aspects of our interactions with the health system. How have you seen in your communities these efforts to link resource coordination with vaccination? How have you seen that affect trust in the health system and or trust in the vaccination process? Andrew, we can go over to you. It looks like you were trying to say something, but I'm not sure we heard you there.
Yeah, sorry, I was muted. I was just saying it's messy. It's hard because it's easy to miscommunicate down the chain and up the chain. It's very easy to miscommunicate. And when we put expectations out there that we're going to be there, we're going to show up, if the perception changes, perception is reality for many people. And so I think that being open and transparent and you just can't communicate enough. I always say, I talk to my wife, 20 hours a day and we still miscommunicate, right? And so, I mean, how can we communicate more clearly? It's really hard. But the fact that the state did offer services and the CHWs are consistently there, I think that consistency is really important. I think that the CHWs are trained and accountable. One thing that the program has is, like, a hotline that people can call in and report. So I mean, there's this accountability process that's really important. And then finally, I would say that it is really hard. You have trust until it's broken. Once it's broken, and it's really hard to fix that. And so it's still an issue. I think there is this historical, obviously, issues that communities are facing and structural issues. And so everybody is pretty doubtful. But when the CHW shows up again and follows through and they have the resources, the community is getting access. They are plugged into the system. So it is hard, but this process is working for the state and Cure Americas.
Thanks, Madania. I saw you nodding there. Is there anything you guys would like to add from Immokalee?
Yeah, it's the same situation that we have here. Trust, I think, so that's the more important, especially when they see familiar face in the community when we doing the testing event and they come to the line. Oh, I'm so nervous. I didn't want to come because I'm afraid if I come positive, I'm can available to stay home because of the family. Like last Sunday, I have a lady, she work in the packing house and she came to have testing with her daughter. Her daughter was a 37-week pregnancy. And it was the second time that she came positive with the COVID. And right now, when I told her that she came positive, she started crying. I can't be out of work because I'm helping my daughter with the pregnancy, pay bills. If I'm out of work, I don't have no money, and most of them right now, what they ask them is go back to work. Even if they're positive, even if they know they are positive, they ask them to go back to work. That's the situation right now that we see in Immokalee. And Mission Peniel, they're doing wonderful work right now with our patient. For those patients, they have to stay at home for 10 days. We have helping them to pay bills, and when we call them to say, hey, we got the Mission Peniel, and at the moment we're calling back, Mission Peniel get in touch with you. Oh yes, thank you so much. I'm really grateful what you do, and thank you so much for your help. It's really nice when we call them and they say all of the good feedback that we're receiving.
Thanks, Madania. And do you think that has affected, as you go back to talk to people about vaccination, do you think that they're more receptive to vaccination now than they would have been before this work existed?
Yes, definitely yes. Especially now they have more confidence. They see more people going on the line and it passing from one voice to another, the one neighborhood to another. Oh yes, I already have it. Yes, go ahead and have it. And since it's really a small town, right, in Immokalee, everybody know everybody here. Believe me, you go to the store and you see a family face. Oh, I see you have the vaccine event. Yes, I work there. And they feel more comfortable. And now they asking for the vaccine. They come in, they're not afraid no more. Before they have a lot of really bad feedback regarding to the vaccine. Now they feel more comfortable. Yes, we need more shots. That's what we need.
Great, thanks so much. Grace, anything to add from Montgomery?
Yeah, I just wanted to add one piece that Madania brought up, which I think is so important, which is, and she touched on it in the context of Immokalee being a small town, but the importance of all the social service providers and community leaders or community health workers being connected to one another, and the importance of that being a web, really, so that a referral isn't made to someone into kind of the dark ether, right? And that there's some follow-up. The person that was on site at our mass vaccination clinic in Montgomery is a local trusted faith-based leader who a lot of folks know. He's intimately connected with the community health workers that will be on site, right? And so he can really make kind of that warm connection with them, and then the CHWs can then make that warm connection with other social supports, community resources, et cetera.
Great, thanks everyone. I'm shifting topics a little bit. There have been a few questions that have come in around mobile vaccination efforts, both in general and then also specifically for Andrew. It looks like one specific to you in North Carolina. But this question of reaching underserved populations and pop-up vaccination sites have certainly been talked about. Are any of your sites thinking of mobile vaccination efforts to help reach underserved clinics? And if so, how? Julie, over to you.
We have a mobile unit for our testing events, and we'd like very much to be able to use that for vaccine events. So we're waiting for a couple of things. One is to be able to access some of the farm workers where they are, get out into the community, and we're waiting for the ability to vaccinate farm workers. So once we get the governor's executive order, we want to be ready to go. There are some complications because of the vaccines themselves and having to keep them cold, and but I know it's being done in some parts. I think it was out in California. There are some places that are doing the pop-ups when we have the ability. We have the vaccines, and hopefully it's the J&J one shot only, and we're allowed to vaccinate farm workers. We want to be ready to go. Boots on the ground. We want to be out there.
Yeah, I would add to that, the farm workers for sure makes total sense, and also testing and vaccination, because you don't want to vaccinate right if somebody is actively sick. And so it's a 2-day thing. It's not a 1-day thing. And also we're adding to that other services. The social determinants of health screening tool from DHHS. So that's one population for sure. J&J makes sense. I would say we had a call yesterday. I don't know, John, if you were a part of that, but where one of our community health workers actually was able to get 20 farm workers to the vaccine event, the mass VMA vaccine event, because of the connections that they had with the farm owners. And so a lot of the farm owners do want their employees to be safe. It's hard to figure it out. Some of them, care more than others, but it's really about those relationships that community health workers have already and those organizations have from other activities that they've been part of. The pop-up events are really interesting. This is where I was talking about this need to prioritize the equity prioritization. It is really hard to prioritize when you're just trying to get all the doses allocated. There's this tension between got to get all the shots in arms, equity first. It's a big tension, but the people in our teams are really pushing back against providers to say, no, hold another day, wait another day and let us do more phone calls. Don't open this up yet. Please wait. We know it'll get filled. Hold. John did that with our event. Our own people have done that with other events, small and big, to just really say this, we need to focus on this. And so when you think about a 65 plus person without a phone in a rural area, it's all of the things that are access, including transportation. How do you get them there? These are all really hard, but it's worthwhile. So you need the advocates as part of the planning to push back to say, no ID required, to say, there is a way to do this all in Spanish as well, to say, hold off on opening up to the public so we can keep access to the populations who need it most. Those advocates in the planning process really help for both the pop-up and the mobile testing.
Great. Thanks, everyone. Moving to another question from the audience. There's a question that came in early on about, have any of the organizations here taken steps to address gender and sexual minorities and those who sit at the intersection of multiple intersecting identities? Considering the higher risk of people affected by HIV in these groups and the lower health literacy affecting confidence in the vaccine, have any measures been taken to reach out to these marginalized populations? For example, town halls or gender or sexuality markers incorporated on intake forms?
So I would say at our where we're at, marginalized is not just people who speak Spanish, Latinx, and African American. There's so many other communities who have been left behind by our system, and so we are holistically looking at all of those communities, including the communities that have been mentioned, including people with disabilities, including the elderly, et cetera, et cetera. And so it is this lens that's different than maybe what we think about usually. And I think that's where the CHW is having the training and building their workforce from communities is so critical. And so for us, it is including CHWs who look like the communities, that age, gender, race, every location, geographic location, all of those things are critical. Otherwise, we will miss those communities, including all of the communities. I think that's just the key here, right?
Yeah, I echo that absolutely. And I think it highlights the importance of having different town halls and different trusted medical experts, trusted messengers speak to different groups of folks and really make the space to have that collective open dialogue and let individuals ask their individual questions that are individual to them through the variety of town halls that we've done in Montgomery with, first grassroots leaders and faith-based leaders, more recently with groups of educators, groups of immigrants, groups of frontline workers. There are some questions that are common, right? Why was the vaccine, why was it developed so quickly? Or should I be concerned about it? Or will the vaccine give me COVID? Or will it get into my DNA? But a lot of the questions were really specific and personal to an individual's experience and an individual's health history. And to make the space for that question, particularly for folks that don't have a PCP or a medical home, to make the space for those questions to be asked and to be answered without judgment has been really critical.
Thank you both. A couple of questions have come in around funding from the audience and asking which types of funding sources have been used, both in terms of thinking about resource coordination overall, and then thinking specifically about some of these resource coordination activities related to vaccination, either these efforts to help people reach vaccination or efforts to screen for social determinants of health at the time of vaccination. Can you guys elaborate a little bit on what types of funding sources you've used? Has it been philanthropic funds? Has it been CARES Act funding? Has it been vaccination specific funding, or a mix of all of the above? Julia.
The funding for the federally qualified healthcare centers has come through HRSA, so we're getting some federal funding for the COVID team. Then we've gotten some CARES Act funding through the county for a lot of the PPE and the materials that we're taking out in our canvassing in the neighborhoods, to the group canvassing, to the testing events, and now to the vaccination events. We've got some ability to use some vouchers for transportation. We've certainly, our friends at Partners in Health have been helpful in getting some additional funding to help with some experiments around providing gift cards for food, grocery stores, to incentivize them to come in for testing. And now that's making it easier for us to get them vaccinated. And also to help support some of the community health workers. We started with a team of 4 or 5 people in the fall, and we're now up to, just started yesterday, our 12th team member. So boots on the ground has been so incredible, and having people from the communities who speak the language and understand the cultures, having them supported by all of these funding sources. So right now it's been those types of grants. We do hope to do some additional fundraising grant sources, but also some general philanthropy for all of the work that's being done there. It's getting a lot of recognition here in our community in Collier County.
Cure America this whole program is funded by the state. Secretary Cohen and her leadership team decided to make CHWs a priority, and this SSP, the social support program, a priority. And what I heard from them was they'll do whatever it takes. There was CARES Act money. There's other ways that the state can direct resources to this to scale it up. And so I'm really proud to work under their leadership. I think that most of our partners have, smaller grants that they're working with, but at this scale, at this, level of professionalism that we're desiring and support needed, there's a cost to it. And that cost will reduce costs and ensure equity, but it's not something that the local foundation it's not that kind of cost. We're talking about 200 full-time CHWs. I think the state has even up to 400, maybe. They have quite a few. That's a big HR and all the support around that.
Yeah, it's a critical question. I wish I had a better answer on sustainable sources of funding for these community-based workforces. In Montgomery, we've been able to mobilize a modest amount of money through a community block grant through HUD, a CDBG grant through the city towards the creation of CHW program. And a lot of those CHWs are doing some of the kind of supporting that, will be supporting on some of the social support integration. Otherwise, there's some CDC funding coming down the pike on this, I know, and also private philanthropy dollars are, if you can access them, are often a good way.
I think that community health workers and this type of equity should be paid for by the health system. Should not be behind a desk, but be in the community. I think the hospital systems can reduce their costs by employing these folks, and I think that's really hard to create those relationships. But I think there's beginning to have traction there when you think about coordinated care management and post-COVID. A CHW, to me, this program is disease agnostic. We're responding to COVID-19, but fill in the blank with the measles or clean water or chronic diseases. CHWs are about the people, and they can get trained and they can go on this career pipeline. But I don't think that it needs to be just COVID. It must be to policy level, long-term, big dollars to make major transformational changes in the health system. And I think that if we can show the value, the impact, and the cost effectiveness, if we can demonstrate that on a small scale, pilot it, start with the pilots, and then scale it up. It's, I'm working really hard to find those dollars. That's literally my job. And so I think that's it's possible, and I think there's a lot of opportunity. I think Biden administration said they want to have 100,000 CHWs across the nation. Let's make sure they're in the communities.
Some great themes there, both around mobilizing multiple short-term sources for funding to be able to get these programs off the ground, using whatever source is available to that local community, but also thinking about long-term sustainability. And I'll just point to a link dropped in the chat about focusing on proven return on investment, and a link there from Mackenzie that may be helpful for folks. We're running down on time for our Q&A, but there's two questions I want to bring quickly to the group. So first, one that came from the audience around what advice or action steps would you give to employers? And I'll expand that to say give to employers or local jurisdictions about how to support community health workers, whether it's through communications or through resources.
I have so many, but I will just say we can't just there's this, like that term people have heard, it rolls downhill, whatever that means. It can't just end at a CHW and that they do everything. CHWs need support. They need systematic supportive supervision. They're not just there to go and do X or do Y. They have a really expert role and opportunity to support the health system. And so what my number one recommendation is, only book them 75% of their time. Leave 25% open, because usually all of us are the kind who work way too much, and we want to avoid that burnout and give space to taking care of all the other things that are really important in programs. So I would just say, don't just keep piling on to CHWs.
Yeah, our team would love to add on to that as well. We were just talking, but so we talked about sort of three areas. So one, I think this job security is really important. I think a challenge with CHW programs that are funded by grants and funded only by philanthropy money is that there's always this fear that the position is going to end in a few months when the grant ends. And I know on our team, we've seen that sort of manifest as people working multiple jobs at one time because they're afraid to leave one job if they're not sure where this one's going to end. So we talked about, I don't know, Madonna, if you want to add to this at all.
Yes, I think so.
So job security is important. And
Yeah.
I think that links to identifying mechanisms for longer term funding. And as Andrew said, really building this into the healthcare system. Second, I think something that we've seen on our team is how important it is for community health workers to be viewed as valuable parts of the care team. They're not just, tools to be used in emergency response. They're people with lived experiences who bring so much to the table.
Yes.
And so I think, encouraging leaders in healthcare and seeing community health workers as leaders in the healthcare system is important. And then finally, we talked about the importance of building structures for self-care into the work of community healthcare workers, because our team is on the front line and we're coming across these very heavy stories. And I think it's sort of exacerbated because these stories are, neighbors and community members. And so it's important, again, to recognize that community health workers, we're human and sometimes need those structures for self-care too.
Great. Thanks so much, everyone. I think we are about out of time there. And so I think we'll have to stop it there rather than bringing up any of the other questions. And I know there have been other great questions brought in both from the audience and ahead of time. So apologies that we weren't able to get to all of them. But I want to thank all of our panelists, and I'll turn it back over to Janae for some closing words.
Thank you all for your answers to these questions. For those of you who did ask questions we didn't get to, we will share the slides from the session and we'll connect you all with our presenters in case you want to follow up with your specific questions as well. We'll also share the recording from today's session in case you want to go back to any answers or share it with your colleagues who might not have been able to attend. So if Melissa, you could go to the next slide. I want to reiterate our thanks to our presenters, to our moderator, Shada, to Joya, our initial speaker, to all of you who are here in attendance, and then to our learning team at the Public Health Accompaniment Unit who helped make this possible today. A few announcements from the PIH side. Please check out our resource library, which is live on the PIH website. We recently released a set of materials, vaccine toolkit, which includes a lot of practical tools for community engagement and for equitable strategy and operations. One particular resource that we'll be uploading there today is a manual that we developed in partnership with CORE on community-based COVID-19 vaccination. And so this talks through some of the operational considerations of setting up vaccine sites of various sizes in various locations. And really throughout those operational considerations, we're trying to understand how we can promote equity and ensure that that vaccination opportunities are getting to the places that need them most. We also are supplementing that with an operational expansion on specifically care resource coordination opportunities with the vaccination touchpoint. So take a look at those materials. I'll send out an email after today's session that will share some of these links as well. We'll have additional webinars on vaccination coming up in April. So if you're in attendance today, you'll receive notice of those webinars coming up. So just stay tuned. We hope to see many of you back with us for our next session. So our feedback poll has gone up. Please take a minute to answer these quick questions for us. And we'll be in touch shortly with some slides, recording, and additional resources. Thank you all so much.
Thank you, everybody. Good work.